speaker, Mr. Rajiv Nath sir. After that, we'll be having the Q&A session. Audience members, please put in your Q&A in the question answer section. We will answer to those in the Q&A session. Rajiv Nath sir, over to you.
Sure, thank you. I think we missed one slide. Can you go back one slide? Or okay, you mixed the two slides together. That's okay. That's fine. So how much time to have, Mr. Raja? Because it's, I think we are behind the time overrun. I can't hear you.
You have 15 minutes, sir, and we can, after that, we can have a 10-minute question answer session to close the session.
Okay, I'll try to squeeze it in within 15 minutes. I had planned 20 minutes, but I'll try to make it faster. So I've been hearing all the stalwarts till now talking about the healthcare and the quality journey they've had in healthcare. Now, and they've been speaking from the heart very passionately. Quality in healthcare cannot be delivered by a doctor as a corona warrior, for example, if he doesn't have good quality guns and good quality ammunition. And this is where we come in medical devices. So without good quality healthcare products, medical devices, a doctor will be handicapped to give good quality service. And this is where we come in manufacturing, where we produce consumables, disposables, equipments, electronics, instruments, diagnostics and implants. And I'm here to talk about the IMED impact in making sure that doctors and healthcare industry will get access to good quality medical devices, and how do we go around doing that? So our vision is to make India to be one of the top 5 manufacturing global hubs. 10 years back, India was nowhere on the picture, and nobody even used the word medical devices. Some people use the word medical technology, some people used different terms, but even the word medical devices was not uniformly applied. I meant for that change. Now, you see on the right side a picture which is a typical crossing in India when we have no regulations or no respect for regulations, and you have traffic jams. This slows you down and it's chaotic life. Next slide, please. Next slide. Can I change the slide from my side? Okay. This is a slide which is showing you Germany, whereby you can see that when you have discipline and regulations, you can go faster. So when you are disorganized, not respecting discipline, not respecting regulations, you tend to go slower, not faster, when both try to go ahead. So it's a very unusual position that we have over here. Hello? Okay. They've left the center through way for the police and the emergency vehicles, the ambulance, to reach the accident site, and then they can debottleneck the traffic jam over there. Everybody on the road knows his role, and they know what the other person has to play. When everybody in a disciplined manner follows his own role, that is what regulation is all about, and that brings better life for everybody. This is what we're trying to achieve, and we don't think regulations is bad for the country. We think regulations, if they are implementable, they are practical, and they are simple, whether for healthcare or for medical devices, they will help the country. Next slide, please. So about medical devices, we already know that historically we've had a lack of trust of Indian devices because we didn't have really a strong industry. Quality was not very sound. There were incomplete and incorrect regulations because only very few devices were regulated under the Drugs Act. And we've had an issue of a regulatory framework which was incomplete and incorrect. We are not pharmaceuticals, but we have been trying to be regulated as pharmaceutical products. So we realized, and we've been talking to so many doctors all our life, that doctors would always ask us, give me a reliable supplier for this product, give me a reliable supplier for that product. Now, how do we tell what is a reliable supplier? We can only say which is a reliable supplier neutrally, without any bias, if he's a certified supplier. So even right now when COVID happened, as an association head, I was getting so many emails from doctors, from associations, from buyers. Give me a list of certified manufacturers of PPE. Give me a list of certified manufacturers. Give me a list of certified manufacturers of masks. And this was a big handicap for us because without certification, what do you provide? Next slide, please. So we decided that there was a need for a separate certification. Now, the Drug Act has been put on devices since 1989, more than 30 years. In 30 years, we've only regulated 23 devices until last year, and 14 more were added last year, so only 37. Because of industry asking for regulations, now from this year, the government has decided to regulate all medical devices as drugs, but under a voluntary system. I'll just explain you about it. Next slide, please. So one issue has been how to encourage Make in India and not to discourage investment, because people said if you bring in regulations, there'll be less investment. Next slide. And second issue was, how should India address patient safety quality concerns of hospitals and doctors? And for that, the answer for both has been that India needs to have a very specific patient safety centric medical device law and a specialized regulatory framework, which needs to be independent from pharmaceuticals as a national regulatory authority. Next slide. What would be the role of the center and the state? Because we have this problem in India that there's an overlap between the responsibilities between center and state. And to avoid an overlap, it is best to have complementary roles between center and state. So the controls need to be decided that there needs to be a sharing of responsibilities and delegation. Center will do certain things, state will do certain things, and conformity assessment bodies will do certain things. Next slide. Next slide. So we introduced a certification scheme with the Quality Council of India. For the low risk products, it is called ICBET 9000. And for the medium and high risk products, it is called ICBET 13485. This is a quality management system oriented scheme. And we are now introducing a product certification scheme built on that called ICBET 13485 Plus. In this whole certification scheme process, AHPI and IMA have been worthy partners of the scheme making. Next slide. So, I don't know if many of you are aware about the ISO 13485. That's a quality management system standard, but by itself, it was not complete. So, we've benchmarked the standard to international regulations, and we decided to add 23 regulatory requirements over that. There were issues that for many products, there are normally no standards available. But doctors should naturally have quality concerns and safety concerns. To address such quality concerns and safety concerns, there are 13 essential principles for safety, which we incorporated in our product standard scheme. Then we added for traceability and for consumer protection and for patient safety, 16 labeling requirements. And this together became, in a nutshell, a composite scheme called the ISO 13485. Next slide, please. So normally you'll find that regulations, if they are there, they will normally be having the bare minimum regulatory standards to make sure that whatever is being made is good for patient safety. But when we talk about quality, quality is much more than patient safety. So every manufacturer will be benchmarking himself to either an Indian standard or an ISO standard, or be making it to his own company-defined standard. And this company-defined standard will be higher than the competition standard. All that he defines is called quality, and that is much more than what is regulatory minimum if he wants to be competitive. Next slide. Over here you'll find we benchmarked the ICMED scheme and the medical device rules which followed later on. So we used the experience of ICMED scheme and made sure that the rules and the regulations which came from medical devices were robust and incorporate all the same elements. So the base of the pyramid is a quality management system standard. On that we've added the 23 regulatory requirements I told you about. Then we've added the 16 labeling requirements. Then we've interspaced that with the horizontal standards which are based on risk management, essential principles of safety, sterilization validation, process validation, and such like things which are required in manufacturing. And on top of that, last comes the product, which is only available in certain cases. And now we are creating the ICMED Plus certification, whereby a particular product from a company who's already certified can be also certified to that ICMED Plus certification. This will give confidence to you doctors that this particular product from this particular company is dependable and reliable. Next slide. And this product certification is going to be of a higher norm than the basic TCGI level regulatory standard. So what you are getting from a licensed manufacturer may be bare minimum. What you get from an ICMED Plus certified manufacturer is going to be definitely more reliable, more dependable quality made to international standards. So doctors can be assured that you can trust these companies. So this is normally the national framework that we have for quality, where you have conformity assessment on the right side, you got standard making bodies on the left side, and you got technical regulator in the center. The same system is also followed for hospitals, the same system for food, the same system for devices. The principles of quality remain the same. Elements can be changing. Next slide. So this is where we've tried to unbundle regulations. Internationally, most countries have tried to make sure that the mistake is not done like we have in India, where the government is the lawmaker, government is the inspector. In the evening, government is also our informal consultant and trainer, and then there is a conflict of interest. So because of the conflict of interest and rent seeking, we do not have robust regulatory implementation. So internationally, the best practice is to unbundle regulations, to have an accreditation body that is separate, legislator is separate, certification bodies are separate, and this is different from what we have done in the hospital system than in our manufacturing system. In hospital system, NAPH is directly accrediting the hospitals. In medical devices, we've added one more layer here called certification bodies. So certification bodies will audit us, not the accreditation body. Accreditation body will make sure that the certification body who audits us is doing the job in a uniform manner and as per the accreditation norms. This makes sure that there is minimum government and maximum governance. Next slide. Next slide. So now, like I told you, from 1st of April, there is a voluntary registration system which is going to be there for 2 years' time, and then there is a further time period of nearly 1 year to 1.5 years, depending upon the risk assessment, whereby licensing will be given to manufacturers. During this voluntary period, manufacturers can go and register themselves on CTSO website. They have to show their ICMED or the ISO 13485 certification. Next slide. And in due course of time, we are waiting for the new law. So this is where the Niti Aayog has drafted a medical device safety, effectiveness and innovation bill. The key features of this bill is to have a single regulatory regime, bring in the various aspects of regulations, and try to make less decriminalization of the regulations. Because medical devices are engineering products, they're not like pharmaceuticals. There has to be a stakeholder sharing with the doctors, the training, the skills. So it has to be done differently and regulated differently than it has been done for pharmaceuticals. Next slide, please. So they have created a system whereby there will be a separate medical device administrative authority with 4 different divisions. Next slide. So the different divisions will be looking after safety, conformance, laboratory enforcement, for example, and this is still under drafting, so it may change. Next slide. And they have proposed that this will be under the Ministry of Health, under the Director General of Health Services. Next slide. And it will be a system which will be parallel to CDSCO. So there will be two divisions, will be CDSCO looking after pharmaceuticals, and one will be the medical device division, which will be reporting to the Director General of Health Services. The next issue we come to across is regarding ethics. So what is ethics? Ethics is your moral compass. Many things in life are not defined under law. But what we've learned from childhood, what we've been taught in the profession, whether you're a doctor or a manufacturer, or as a professional, we all have our moral compass, which is our ethics. And this is the ethics that what do we need to do? How do we treat the doctors, need to treat the patients? In the absence of an act, how do manufacturers make sure the quality of the product is good and safe by self-regulations? And how do we treat our clients in a fair manner? And what is fair and unfair? That is also the ethical part of it. So there are certain key parts in the ethical dilemma, which normally we've been put forward these questions by doctors to us, that is it okay? And manufacturers would ask me that should we be competing only on quality or on price? Are we going to be competing on making more profit margin available to the hospital, or shall we compete on more specifications and performance? So this kind of ethical dilemma is there. When a manufacturer is trying to sell to a hospital, he finds that the purchase person says your quality is good, but your price is too low. I'm sorry, I cannot buy. So manufacturer gets confused. Why you cannot buy the product? My quality is better and the price is cheaper. But the hospital will say, because I'm sorry, our owners want more profit. So your MRP is too low. We don't have enough profit margin. Please increase the profit margin by increasing the MRP. And this becomes an ethical dilemma for the ethical manufacturer. Is he supposed to looking after the end client, the patient, and keep the price as low as possible? Or has he now to print a higher MRP and satisfy his immediate customer, the hospital? Next slide. So the problem is the hapless patient. He is caught between a very expensive, profitable and profit-oriented private healthcare system, and in most cases are not so effective and a redundant public healthcare system. So where does he go? He doesn't want to go to the public hospital because the quality of care is not so good in many cases. Of course, there are many good public healthcare hospitals, but not all of them. And the same way for private. Not all may be very expensive, not all may be unaffordable, but yes, there are many which are unaffordable for him. So he is caught between the two. So we have to define jointly between ourselves, between your healthcare industry and us as medical device manufacturers, and we are a part of the industry, that we have to move not only for giving healthcare, but also we have to give to human care. So the choice of the brand, the quality of the product, the procurement decision-making process, the issue of the profit margin, we have been discussing and debating for quite some time. And we've been told that hospitals would say that we need to cross-subsidize, but that would not bring in cost efficiencies. It does not give an advantage of fixing responsibilities on a profit center or a cost center and making sure that where we can reduce the cost and become more competitive. So the trust issue has now been affected. Patients are questioning the credibility of the doctor and the hospital. They question, and the lack of trust comes out in anger, and this is avoidable. So to bring in trust back to the system and the respect which we have for the doctors, both as sellers and as users of the system, it is important that we create a fair system for manufacturers, a fair system for the hospitals. So by doing that, we create a benchmark on the trade margins. Next slide, please. So we propose that we can have regulations to regulate the trade margins that will cap the profit margins available to the retailer, the trader, and even the hospital selling the product. Hospitals need to make business and make money. Chemists need to make business and make money. Manufacturers need to make business and make money. But we need that money for profitability, for growth. We don't need to be seen as profit making. So either we can self-regulate ourselves, the healthcare industry and the device industry, and if we will not do it and follow ethical choices, then we will be forced to be regulated. And when regulations come, sometimes they come with over-regulation, which is avoidable. These are our thoughts. And from IMED side, we have been in constant dialogue with AHPI, with TAHO, with IMA, the various stakeholders, and also the government, and trying to impact and create a win-win ecosystem for all of us. Thank you. Next slide.
Thank you, Mr. Rajiv Nath, for a insightful session on what is boiling in the Indian medical device and various other affiliated industries. And it's very important. When I was discussing with one of the speakers who's also going to be speaking in our next session, Ms. Rama Vedugopal, we also wanted to bring in that medical device and industry into the perspective from a hospital administrator or a quality manager or even a hospital owner's perspective, what and all is happening in that. And you have given us a very good insight on all those. Thank you very much, sir, for that. And our panelists, would you like to add on anything on that?
I think it was very important to understand from the devices perspective. We never realize, we always say that you need to reduce cost and keep reducing and keep arm twisting. But there are, we never realized the perspective from the device industry, which was very well brought out. So thank you for the fantastic presentation.
Welcome.
Thanks, Dr. Sanjeev. Anybody else would like to go for it? Okay, thanks, Rajiv sir. And I would like to draw your attention before we get on to the Q&A session on the part 2, the session 2 of this particular webinar, Quality Accreditation and Beyond Winds of Change. It's coming on the 31st July. We have excellent panelists lined up for that as well. You have all received the details of it. We have Dr. Rana, Dr. Alex Verghese, Dr. Umashankar Raj, Mandakini Pawar, Professor Mr. Rahul Rao, and Ms. Rama Venugopal, who will be doing the session next week, same time. And we'd be happy to have you all. Now, over to the Q&A session. The first question is to Dr. Sanjeev. What were the challenges faced while introducing PROM and PRAME, and how did the clinicians invited this idea? This question is from Aishwarya Chandrahasan.
Thanks, Aishwarya. I think bang on, difficult question, not an easy answer. So when we wanted to introduce this, why they said that, why my department? Because are you suspecting something that we are not doing right, and that is why you're into orthopedics and cardiovascular? So they always think there is an hidden agenda. They never realize that there is a new tool, and they are very excited to get into it. So it took a lot of time. What I realized is we are very colonial in our approach. So if you bring in an outsider from UK and US, people listen. So we brought that lady, and they all heard her, and they said that, yeah, why not my department? So then it became slightly easy, but then getting to the formats, because then soon we realized that these formats has a price. So ICOM formats, and because it's attached to Harvard Business School, anything which Harvard does has a price tag. So then we somehow got, we then pleaded being charitable. So we got some of these formats. We then got 3 or 4 formats clubbed together to understand what would work best. And then I think once we were communicating well, we did a pilot and we did well, and then the surgeons got excited and it matched, basically it matched their own success rate. And the patients come back and said that your medical social worker kept talking to us or your resident doctor kept talking to us, and they were very happy. So then so 2018, 19 went.
Dr. Sanjeev, we have you here.
Yeah, I'm done.
The panelists would like to add on to that.
Sanjeev, that fetish with the white skin, even the government has banned fairness creams and most of the companies have taken off. So, and it's the era of Atmanirbhar industry. So I think we must rely on our own standardized protocols, developed indigenous tools, and we must take it further actually. And I think that's the only way out. I mean, though we respect every institution which has helped and developed and validated their own tools, but now the time is very right to start collating our own data and bringing out, because nobody can beat us in the number of population and the volume. No? The scale of volume is in our favor actually. I mean,
Power of NAPH is the power of volume.
correct.
650 plus hospitals, so we can easily bring our own formats and validate those formats and let the world use our format. So
it is true that it is true that JCI has about 35 to 40,000 institutions, but the population which they are dealing, actually they are a country 3 times our size with half a population, and what we are trying to do with 700 hospitals is a much larger chunk of data. We only have to streamline. The moment we do that, I mean, the world will come knocking at doors.
sure, perfect.
This to Dr. Atul Kocha. Quality NABH certifications are for reputed hospitals. What about status of quality for hospitals in remote area and government hospitals? I consider the questioner a little biased, but I know for sure NABH and all the other people over here are doing a lot for the government and smaller hospitals across various parts of India. Can you just take us through that, Dr. Atul?
So this is a fantastic question, very, very relevant and thematic. Actually, we have one body called NHSRC, National Health Center Resource, this thing, which have their own standards actually, and their own assessor, which is for public funded body, which is a checklist-based approach to handheld. We also have an increasing trend of public funded institutes going in for NABH certification and accreditation. We have currently 112 public funded institutes under various programs. Just to place on record, all institutes of repute under Ayush are NABH accredited, which is a very proud thing. Amongst the all, if we were to talk about AIIMS, let's say, so each AIIMS has a medical MHA department, a hospital administration department. They all are compliant. But because of logistic reasons, see, I mean, one basic difference between like the hospital where I come from, actually, and I was looking after the admin of that, is a 2,500 bedded hospital, Lok Nayak Hospital of Delhi, which is a dedicated COVID, is a 2,500. And when we say 2,500, we do not mean we put a cap at 25. We agreed to take patients. We cannot deny a patient. Our consents have a built-in clause that we will that patient will not object if we have to keep him on the floor or on a trolley. I mean, that's the kind of challenges which we face. And our skin OPD is 1,000. Our total OPD is touching about 10,000 to 15,000 per day. So these kind of mind-boggling figures when you deal with. So these standardized set norms of quality, the logistic wise, can take a little challenge actually. So these are the challenges, but not to say government is trying very hard to bring in standardized infrastructure. Most of the OTs are modular. Most of the best work is being done. All these standards, if not in total, I mean, they are compliant. So today, I mean, because the public demands where their taxpayers' money is going, so government is very, very receptive to such changes. So day is not far when when standards will be there. And in Delhi itself, if we were to talk about entry level, there are 14 hospitals which are entry level certified, so which is a very good beginning. And some of them are really world class. The Maulana Azad Dental College is the first college in Asia actually amongst dentistry, and you have to visit there to believe that such a setup can exist out of a, I mean, this is better. I mean, this is a experience visiting that place. So blanket statements would be justified, but the question is correct that public funded institutes also need to comply with these norms. There are various sets of challenges because people who visit there also deserve that kind of quality, and so some accreditation benefits they must get. So I totally agree, and we'll try to push. Talking about tier 2, tier 3 cities, we are reaching them, and we are also working out a low cost clinic based centric where will not self actually, just like a PAN number. I mean, when you say that when the PAN numbers came in, government encouraged you apply and you get it. So we want people to understand that quality, if not the complete standard, at least basic steps of hand hygiene, that are very basic steps of patient responsibility, patient duties. So I mean, that kind of thing. So what are the 7 patient centric goals which are there? So what is universal health coverage? So basic things we want to put in place before we can build on that foundation. And as the large country, it's a big country, and we are the second most populated country, so challenges will be there, but we have to customize our tools, customize and approach in a graded manner, and we are working some things out actually. So maybe over the next year or so, because COVID has changed everything, there's something, so with new, everything will have to be done new or fresh. So we are positive. Let's see how best we can take it forward.
Yeah, thanks, Dr. Atul. Over to you, Rajiv sir. People are confused about N95 mask. So, which is the N95 mask to use? Is one of the question. And there have been a lot of question on reusable PPEs. Are we going to see the daylight of reusable PPEs?
Okay. So, can you hear me? Okay. So, regarding N95 mask, the basic N95 mask, for which we have an Indian standard called IS 9473, is an industrial mask. So when it is being applied for medical use, it has to be then adapted for medical usage. That is why you'll find many of the healthcare workers, they are using the mask with a surgical mask, because the N95 mask is designed only for industrial pollution and it's not splash proof. So people are keeping a double mask of a surgical mask to also have the bacterial safety factor on that. And now the most recent controversy has come of the valve, whether to keep the valve over there or not. So if a healthcare worker is in an ICU, where the healthcare worker has to protect himself from an infected patient, then in case, because it's very hot inside the PPE, he needs to breathe out and exhale. So in that case, the healthcare worker needs to have the mask with the valve, so he's able to breathe out. But the same mask, which is now being worn in the public outside, because it's fanciful, expensive, supposed to be the highest safety standard. So anybody rich wants to have the best, and if you can afford it, why not? So they've been buying this mask with these valves, and that's why DHS just reported a warning this last week that these masks are not meant for public use, because in case you're infected, then you're going to be passing on your infection as a symptomatic patient to somebody close to you. So the valve will not be restricting what you're exhaling, your infection. That is why they're recommending the mask without the valve. That is why the safest way is to go in for the surgical mask. The N95 kind of mask should be used only inside the ICU with the patients, not outside normally. The other issues regarding PPE. For PPE, you can have which will be single-use design or multiple-use design. So both kinds of technologies and fabrics are available. For single-use or multiple-use, it's based on your buying specification, what you ask for, and you look for the right kind of supplier you'll automatically get the material accordingly. The bigger issue is not about single use or reuse. The bigger issue which I have seen in the last 3 months is about comfort. So most of the manufacturers, unfortunately, only who came into the trade recently have been making the PPE based on only making sure that it is having a viral barrier and made it like a plastic raincoat. But that made it so hot and uncomfortable for the doctors and for the healthcare workers that they're sweating inside. So a good quality manufacturer will be using a more breathable fabric, which will allow the barrier for the virus and also fluid protection, but also have the micropores to allow the air to go through. So you're able to breathe and your body can perspire and then you'll be more comfortable. So what you will ask for, you will get. Thank you.
Thanks, Rajiv sir, on that. And a question to Dr. Lalu. Can you advise us on the SUD for multiple uses, especially in diagnostic and cath lab? No, that's always a burning topic in hospitals. I have faced it as well.
Yeah, I don't know if I'm the best person to advise on that, but I can tell you exactly what we all do with regards to single-use devices. Now, this is a major area of concern in most hospitals, particularly in the cardiology. If you have a cardiology department or if you have a DSA facility where many of these single-use devices are being reused. Now, what do we typically follow? Am I audible, Rajaraj?
Yes. You are.
Yeah. So what do we typically do? We first identify all those single-use devices that we reuse. We put them down very clearly, and we also have a sterilization protocol for that clearly drafted out. Whether it is ETO sterilization or plasma, how are we going to do it is something that we clearly spell out. Number 3, the number of times of reuse, that is based on the discretion or the usage. You ask a cardiologist, he will say this particular device will probably last for 3 times, 4 times, after that it becomes blunt. So depending on the number of times it can be reused, we specify the number of times it can be reused also. Now, the fourth important component, which is the most important, is informing the patient that you are actually reusing a particular single-use device, which means we tell the patient, let's assume if it's a stent or something that we are reusing, and that stent costs about 10,000 rupees. We don't charge the multiple users 10,000 rupees. We tell them it is a reused one and proper sterilization practices are being followed. And therefore, we are charging you 2,500 rupees because cost is extremely important in particularly our kind of setup in Christian Medical College, Vellore, or any other. I'm sure Amrita must be doing the same, where the clientele that we handle is something very different from other hospitals. They are neither in the government setup nor in the corporate setup. So we tell them very clearly, this is what we are going to charge you. These many times we reuse and we also assure them the sterilization efficacy of the device that we are sterilizing. There is a consent which is incorporated, and that consent is also taken from the patient to that effect in the language that they understand. But this is very strictly followed. Now coming to N95, also we sterilize and reuse. To be very honest, with the non-availability of N95 in most healthcare establishments and the numbers that are required for managing, what we currently do is follow the AIMS pattern. AIMS does it A, B, C, D, E, 5 masks, 25 days. What we follow in our institution is 3 masks for 9 days. 1 round of plasma sterilization, another round of 9 days. It is good as long as the fit is good, we allow them to use. We tell them very clearly, if the strap is not broken, if the fit is all right, you don't see a leak, you continue to use. But we avoid that in the COVID positive areas. In the COVID negative areas are the so-called orange zones. We have put this protocol in place. In a resource limited setting like India, we cannot do away with reuse of single-use devices. And that's my very humble submission. We can't add on cost to our patients. There are very good devices that have come in the market, particularly developed by Fortis, and now that is marketed, very supported by the government of India, particularly with cardiac catheters, which are used for reprocessing of single-use devices. And that's approved by the ministry as well. We are going to embark on a trial very soon. So I don't think we have reached a position that we can say we will not be reusing single-use devices, but it is for us to develop, design the protocol, follow that strictly, be ethical in what you are doing. Don't charge every patient the same price as what you would charge for a single use. And that's my humble submission.
Can I come in?
Yes, sir.
So this has always been an interesting debate, and we've been in a dialogue with the Ministry of Health and ICMR on this, both from the point of view of ethics and point of view of regulation. So the product needs to be basically be labeled either for single use or reuse. Right now in India, we don't have any regulations for reprocessing of reused devices. And we do understand that, of course, single-use devices like a syringe, if it is going to be reused, it's going to be having more risk than benefit. It's always a question of balancing risk and benefit. But you can't compare a disposable syringe to a 15, 20,000 rupees catheter of a guide wire, for example. So when you're going to be reusing a guide wire with certain possible constraints and in discussion with the manufacturer, then the question has to be seen, what are the materials of construction? Whether it is steel, cleanable, whether it is plastic, whether it is rubber, whether it is a hard plastic or a soft plastic. If a soft plastic, PVC, which can leach plasticizers or not. So by having proper discussion, one can decide whether it can be reused 2 times or 3 times or 4 times. And I think only after discussing and having the proper system, we should put into place a validated labeling system whereby the manufacturer also is protected. The patient's affordability concerns are being addressed, and you doctors' ethical dilemma also is being addressed over there of a limited reuse taking place. So depending upon the design and materials of construction, the labeling needs to be designed as to how much should be the limited reuse taking place and by what method of reprocessing and digitalization, whether by autoclaving, by EO gas, by oxygen, by ozone. So it depends. Some people are putting it at the UV and saying it's being sterilized now. That may not be happening. So this is a very gray area, and I think CAHO has already done wonderful work on that. We've had some meetings in the past with CAHO and with ICMR, but it's been going and stop and go. We need to make it go to a logical conclusion and come out with a white paper and submit to the Ministry of Health. This is our submission from the industry, both healthcare and from the manufacturer side, so that whatever is done, I think, in a scientific manner. And then they can make regulations about it so that the patients not randomly that some CAHO accredited hospitals are giving this advantage and some not. Then every hospital is bound to give that advantage to the patient and not be charging for a full price when he's giving them a reprocessed product. Thank you.
Absolutely. Rajiv sir, it's time that we start working on it once again and taking this forward for the benefit of patients and also the hospitals. Let's work on it immediately.
I think the answer has been, it's been a very interesting discussion, and the first thing, as Dr. Lalu said, is to have a policy and then adhere to it, because cost benefit ratio is very important, because obviously not for a syringe but for a spider or a octopus, these are expensive products. But ethical considerations are very important. And during my assessor days, I mean, few years back, I've seen some wonderful practices in certain hospitals by the way of marking. They have a very systematic way of marking these small guide wires, 1 line, 2 line, and they adhere to that actually. And it's a reality actually. So we cannot just bury our heads in sand and ignore the thing. We must address it well. Introduce the elephant in the room and address it properly and come forward that this is done. But the patient should not be penalized. Patient should be informed upfront, and that there's no harm in it. Even keratosis, that LASIK blades are used. I mean, these are very expensive propositions. So like cost conscious society like India, resource challenged, it's rather criminal. And talking about masks also, even CDC has a guideline. Even 3M has brought out a very detailed guideline how to reuse your mask. And AIMS protocol, and I'm now aware of the CMC protocol also. These are wonderful methodology, provided we take due care. So solutions are there. These are not jugaad. These are industry endorsed solutions, which we must, as a collective, bring out and then place it in domain so that it does not remain limited to CMC or AIMS or other institutes, let's say. So let's bring out a collective thing and promote it as a country. Actually, I think there's a
So
need
what I
for that.
recommend, Dr. Kochar, is in the first phase, if CAHO, AHPI, and NABH jointly
Sure.
can list out the various devices which are expensive and being reprocessed and being reused. First,
Correct.
the list. Second is you make what you think are the best practices based on your internal discussions. And then you share your best practices and that list to our association. We will review with the manufacturers, discuss what are the materials for construction and what are their thoughts from the engineering point of view and issues which may be causing maybe more risk than benefit. And share that outcome with you. And then we can have a joint discussion in groups of various categories of products with the categories of manufacturers, come out with a white paper on that, and then table that white paper to ICMR and to Ministry of Health.
Absolutely.
So that's a good idea. That's a very good idea. We are willing for that, and there's no harm in it actually. If we come together as a joint this thing industry and highlighting the strengths and the weaknesses of the issue. Of course, ethical concerns will remain around. I mean, they are gray because they are ethical. Ethical and gray go together. But we have to have a document in place, at least highlighting the issue and the solution thereof. So,
Yes.
which will bring up more debate and discussion and improvements. So I think this is a good idea. And best practices club we were discussing with Dr. Sanjeev also. Every hospital must come forward to discuss their best practices on a periodic manner. And NABH will provide that platform to all our partner, and everybody can learn, because jungle mein more nacha mein kuch to dekha. I mean, if you create a protocol, if you create a good practice, then it's only ideal that the entire country follows that, entire world looks up to us. I mean, that's the ambition which we have, and NABH will provide that platform. No conflict in that.
Not only that, it goes into the design of engineering. So, for example, like endoscopes, if you don't have designs which are going to be capturing dirt or muck, so even if you try to wash them, clean them, brush them, if they're smooth surfaces, they are much more cleanable, wipeable, and more easy. If you're using stainless steel or titanium versus plastics, so all these things can be jointly be reviewed and put in over there, which can
Support.
give benefit to the consumer.
Yeah, with people like yourself who are experts in their field. I just saw the name of Rama Madam also, Rama Venugopalji. She's the doyen of all this. I mean, quality management in devices, and there are so many others actually. So we take experts, each specific, we get together, and the list can just be populated and go on. I mean, we can carry on with that population because it will only increase with time. It's a good
So
idea.
I'm happy we are having this discussion, but want of time, I need to call time and get to a close to this session. But cheers to new beginnings, and thank you all my speakers for being there and giving very nice insights to the audience. Over to each of you for your closing comments, and we'll close it off from there. Dr. Atul, you can start with it.
Okay. So quality accreditation and beyond, actually, the topic was quality accreditation and beyond. All of us are on the same page with that. Winds of change are winds of change. So nobody has seen the future. None of us actually. We are not Babajis and other things, but we are very positive about the future. We are very hopeful about the future, and we also agree that we have to change. We have to change and adapt and bring in the best practices. We have to work together as a whole, and we have to connect with people. We have to be people friendly, and NABH at least is willing to go that extra step in all directions, and we are open to suggestions. Actually, we also realize we cannot do everything ourselves, so we'll need the support and active cooperation of all our partner hospitals, all our members, all paramedicals, and we are positive. So that's the only small submission, and we are learning with every day. Actually, we are learning and improving and trying to improve. Effort is the only way we can do what we can put. The results, let's see. Hopefully, will. Thank you so much.
Thanks, Dr. Atul, for those wise words. Over to you, Dr. Sanjeev.
Thanks, Mr. Raj. I think I should congratulate you for organizing such a fantastic webinar. I really enjoyed listening to all pearls of wisdom. It was really enlightening for me. I think as a last word, there's so much of work which has already been done, and there are so many islands of excellence. I would steal words from what Dr. Atul said is to network, because the islands of excellence exist and they are doing fantastic work. They need to all sort of come together, and NABH has created that platform, which is very endearing. And if people can come together, share those practices, and I think we need to take it to a next level if we have to go beyond. One, do best practice. Second, benchmark. Third, create our own data, mine it, and publish it, because that is where I think the power lies with the data, and it's a gold mine in India, and especially with NABH. So many initiatives, so many good work which is being done. So that is the power, and I think we should encash on those power. And once you start publishing it, the world is going to recognize that there is some quality. You can on it for some time, but then once it is published well, and you use that platform, so we are sitting on a gold mine. We need to encash that. And thank you again for organizing such a fantastic webinar.
Thanks, Dr. Sanjeev. Talking on data as the gold mine, that's the best thing that I could hear, because we are trying to empower hospitals to work on this digitalization and try to mine the data properly and come out with various papers, come up with a lot of real world examples and real world data, which is going to be a forwarding thought. Over to you, Dr. Gyani. Thanks for joining us. We know that you had certain issues with respect to your Wi-Fi and other stuff. For your closing comments, Dr. Gyani. So your audio is not on, sir. Dr. Gyani. Dr. Gyani, your audio is not on. Hello? So we are having some issues there. Over to you, Dr. Lalu Joseph, for your closing comments. We'll come back to you, Dr. Gyani.
Thank you very much, Raj, for that wonderful opportunity. And I strongly believe quality is everyone's responsibility. It cannot be individual's responsibility at all. And it is extremely important that all of us come together. It is a synergy that makes it happen. So for organizations to come together, for everybody to come together and to work towards quality, and that's when we can build a strong nation, which has its base on quality. So I strongly believe in that. And thank you very much, Rajiv sir, for that insight. I think it's extremely important that we work together, all of us work together and bring out good guidelines, which will definitely help our stakeholders, our hospitals, our patients, and everyone. So it is a collective responsibility and we are all in it together. Thanks once again for the wonderful opportunity provided. Thank you and stay safe.
Thanks, madam. Thank you very much. Over to you, Rajiv sir, for your closing comments.
Thank you all. Wonderful experience. The last 4 months has really motivated me and also opened up my own eyes that so much could be done in 4 months' time in terms of manufacturing, in terms of addressing shortages. But with the good also came a little bit of bad. A lot of new manufacturers came in during COVID times, trying to address the national emergency, and in their haste, there was also some waste. The quality was not sometimes up to the expectations because there's a learning curve involved, and that learning is still not over. But what is of bigger concern to me is not when somebody is honest and says he's still learning. For me, it becomes a concern when people start taking shortcuts and start using fake certificates, unauthentic certificates, claim they are CE marked, claim they are US FDA certified, claim they have got ISO 13485 certification, and they try to mislead consumers. And when the buyers use their product, they find that this is rotten quality, not up to the expectations. This gives a bad name to Make in India. it gives a bad name to credibility in the country. So my request to all of you doctors from all the associations is that when seeking to buy a product, kindly seek for a certification that is accredited by NABCB UCI. That makes sure that it is an authentic certification. Seek IC-made certification from the manufacturers, because that is many more steps beyond an ISO 13485 certification. That'll give you the confidence that what you're buying is definitely a dependable and reliable quality going forward, and it will be more than what the regulations ask for. We manufacturers, my message to you is, who are part of this seminar, certifications have to be earned. They have to be practiced every day, whether in a hospital or in the factory. They cannot be bought. Thank you.
Thanks. Thank you very much, Rajiv ji, for those words of insight. And I'm sure the intent with the manufacturing people are right, and they want to earn these certificates, just like how all hospitals want to earn all these accreditations and stuff. We are in a very funny world, and we have overshot the time by half an hour. And I would just like to quote on what one of my favorite quotes: never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has, by Margaret Mead, a very famous anthropologist. And today, we all have come together, about 550, 600 people who have attended the session at various points of time, to discuss on quality accreditation and beyond, the winds of change. And I'm sure each of you have something or the other that you have taken back from this session. And there is more to it. We have the session 2 coming up next week. And as QurHealth, as Global Mantra Innovations, we have much more to offer for your hospitals and for the patient care. So we would be connecting with you, we would be partnering with you, and we would be together upheaving the healthcare in our society. Thank you all. It's been a wonderful day with all of you together over here. Thanks.
Thank you.
Thanks for organizing, and thank you all.